Michela, you can hear me, correct?
Yeah.
And you can see the,
Okay, is the camera adjusted? Can you see the camera here?
Yeah.
Okay, all right, we're gonna get started then.
okay.
So Kyle, you
Yes,
know what
sort
we're
of.
doing here. So we have the patient intubated with a 7.5, 7.5 ET tube. And Kyle already did the history. And Michaela's gonna put in a, excuse me, an ultra thin scope with a it's a 3.2 OD and 2.0 channel that she'll navigate with. Once she gets in, we'll do the, actually, let's do the spin now. Let's do the main carotid spin
Okay.
right now, okay? So we'll do the main carotid spin
Okay.
first. Okay. You should be able to see,
Main carina there. The main carina is quite visible. We don't need to go with the scope to mark
no,
where
we
it
don't need
is.
to. We're gonna do it right now. So,
Okay.
can you guys see the screen here?
Yes.
Okay, so we're gonna start the spin. Do you want to get ready? Put it into 30 degrees?
Yep.
30 to 30?
Absolutely. Mauro is ready with the spin.
Maori, good.
You are ready with that, and I'm ready with the spin.
Let him go to 30.
Up and down.
Okay, no, you're okay.
So this is the registration process for LungVision. They're going to do a spin
Okay,
around the main.
whenever we are ready. 1, 2, Mauro, go. Spin for the carina.
This is
Now
so
we're
you
doing
can
that?
harmonize that plan that Amir showed you with reality.
Benito?
Okay.
Okay, so now that the spin was done, tell me.
Now we
No.
go back to anterior posterior.
0 degrees.
Yep.
So now we're just gonna wait for the main carina reconstruction to occur. It should take about 20 seconds or so, 30 seconds. No, not yet. Not yet.
Now,
Not yet. We have to do the ISO center first. Okay, so can you guys we can see the screen. So what I'm gonna do is I'm gonna find the main carina on the CT. We're gonna line it up with the red lines. We're gonna find the main carina. Sorry, my fingers are fat. We're gonna find the main carina here. We're
right
gonna line
there.
that up. And then once we hit marking complete, it's now gonna tell us where to move our C-arm so we're isocentered around the lesion.
3 centimeters.
So we need
Down.
to decrease the OID, which means the bed needs to come up 3 centimeters and 3 centimeters. Okay, and then 3 centimeters to the right.
To the right.
This is so
3
you can
centimeters to
optimize
the
your
right.
isocentering.
The bed to the right. Yeah.
To the right. Or
Should I try?
this has to come to the right.
A little bit more to the right.
Tap, the tap.
One more. Okay.
Good.
Okay. The bed down
8
by 2
centimeters.
centimeters. Down by 2 centimeters. Okay.
That says 8 centimeters to the right.
And then 8 centimeters to the right. Bed to the right.
So they've aligned in 2 planes, as you can see. They've got X and Z, but they're still working on Y, it looks like.
No. The bed has to go that way. The bed goes that way. Sorry, Kyle, with the artist, so I'm not moving the fluoro screen, I'm moving the bed, so we had a little confusion there. Okay?
Okay. Bed to the left. Back by 2 centimeters. Okay.
Do another tap. So we're looking for 3 checks in all 3 planes.
Okay.
So now we're going to do the isocenter. The isocenter is done on a breath hold. So APL 20 and an inspiratory breath hold.
Yes.
Whenever
Okay.
he's ready, and then we'll go from like 40 to 40. Okay. So whenever he's ready, he can go into breath hold.
Okay.
So,
We need to.
APL 20, inspiratory.
so the purpose of this step is on the planning CT, you've marked where the lesion is. That CT was
Okay.
done without a breath hold, without anesthesia, without paralytics, without the patient, at full TLC like it was on the CT. Because now, so the CT to body divergence that kills us on every form of navigation, this is how you're going to compensate for it. So now they isocenter it over the lesion. They're going to spin. We're going to now mark where the lesion is located so that the augmented fluoro is legitimately the lesion. Similar things that you've seen with cone beam CT, but they're doing this with the standard, or this is capable with a standard C-arm. That's another 20-second spin, give or take,
Yeah, we're spinning a little slow with the Zebra, but we're good.
maybe 30.
Okay,
The system's run off this tablet.
okay. Spin complete. Okay, so the spin is complete. You can come back to AP. And now we're gonna wait for the reconstruction to happen. You can still see the screen, right, Kyle?
Yes, and as Amir pointed out, so you can do this with a thin scope, you can do this with an ion, you can do it with a monarch, an ambu scope, whatever, just a scope, because it's agnostic to what other underlying technology that you're going to drive.
Okay. So, you guys can see the
Yes,
screen.
another.
So what we're gonna do is we're gonna mark the nodule where we think it's most, where we think the center should be, which looks like that.
Yep, there's the
And then,
CT.
and then we're gonna, sorry, I'm not a hand model. So now we're gonna find the appropriate spot
Perfect
on the
there.
spin. That looks good. And then what we'll do is we put on
Final.
tomo,
Coronal.
right, to see if, and it looks like we're trying to mark around the same exact spot.
That's the AI tomo, so
Looks like
that
that.
is the ability to look now at a fluoroscopic tomo image
Yep.
as if
And
it was
now
an
I'm-
actual CT scan.
Now
Axial,
I'm in
coronal.
sagittal. Now I'm in coronal. Now I'm in axial. I feel good about that. And I'm gonna go to the 3D view, which we don't necessarily need, but there's the nodule right in there. I'm gonna say finish. And then I'm gonna give you a 2x. I'm gonna give you a border only, and then you're ready to go.
So what they've done now is they know exactly where the lesion is today,
Sections.
right now, intraoperatively. And so whatever instrument she's driving out to there, she'll follow her airways and everything else, but ultimately, when she steps
Okay.
on fluoro, there's gonna be a yellow ball. And that yellow ball is the most truthful thing we finally have, because
step
you
on
just
fluoro-
marked it. And a lot of times, these are fluoroscopically invisible lesions. This one may or may not have been visible, who knows? But you'll see it, and you'll see it in different planes.
Okay. They should be able to see it now. She just tapped on the fluoro.
So that's the tablet that runs it. Now we're gonna look at the fluoro screens. Maybe.
Okay. Now, we need a picture of the fluoro screen. We need a picture of the fluoro screen.
Scopes been beat to hell.
They don't see that. Kyle, do you not see the fluoro screen?
No, right
Oh,
now,
you don't see the
we
fluoroscopy.
can only see the Bronx screen.
You can only see the Bronx screen right now. Can you see that screen?
Should be the first one here.
Yeah, let me know when you see it, Kyle. They're working on it right now.
Can they see the bronchoscopy
Now we can see
instead?
now we can see the fluoro screen.
Now they only see the fluoro screen, not the bronchoscopy. Okay, she's
Allora mi
gonna start heading out there when she gets into the
Clean up the scope.
she'll turn the fluoro back
So
on.
the yellow circle's the lesion. Okay, yep, we can see the fluoro screen, Joe.
Yes, she's getting it.
Ooh, picture.
Can you see the bronchoscopy
Now
now?
we can see both, yes.
Yes, they can see both. And then once you get out to the apical segment, you turn the fluoro back on. and
Right upper lobe,
just drive with the fluoro.
apical segment, yeah.
Yeah, it's just.
First branch here on the right. Yeah.
Okay. So you guys can see that. Kyle, you can take over.
Now, obviously, she'll be able to drive however close she wants to drive or to the limits of the scope, et cetera. Radio
Big
probe,
one here.
sheaths, instruments, whatever, just get things into the yellow ball. That's the goal here. And anytime she steps on fluoro, you'll see obviously the updates. So between your knowledge of the CAT scan or whatever guidance system, if you were partnering this, like say with a robot,
Yeah,
but
thank you.
the augmented fluoro is ultimately what you're trying to do. And if you're not sure you're perfectly aligned, you can do a shot in LAO
Not
and
that
RAO as
one,
well
probably
and still
the
see that
other
you're
one.
pointing towards the yellow circle.
Yeah. That one is perfect. Can I have the radial probe?
She's gonna start to put the radial probe out now?
Yep, great.
Yep.
Yeah, Joe, we can hear Michela as well, so it's,
Oh, I'm sorry.
Did I
No,
let
it's
one
okay.
there? Thank you.
Joe, once she puts the radial probe out, can you go LAO and RAO just to show that,
We-
obviously,
we
if she's
will.
before it and behind it?
So they asked, once the radial probe goes out, they want to just do a spin into LAO 20 or
Absolutely.
just to confirm that we stay within the ball.
Because of course in the AP,
So I'm
we were
just
all
going
worried
out with the
whether
radial
behind it or in
probe
front
right
of it.
now. Not yet.
And as you can see, she's used very minimal fluoro so far, other than the spins. But-
Come back.
So you're mostly using it as a
Doesn't
scope,
bend
right? And then,
perfectly. I have to come back and put it out
So she's
now.
having a hard time getting
That was too much.
the radial probe around the bend. And
Yeah, it's because
go
it
back
was
to
bended.
with the
so here's
Now
the
I
key
go
thing.
back to the same position.
So Joe, here's the key thing too. So in the off chance that she can't make the turns because of the stiffness of the probe, if you had a scenario where for whatever reason you couldn't use the probe, or let's say the
Not
probe was
that one.
broken, if you can put an instrument out and then in multiple planes or do the spin and see you're in the lesion, that's the same confidence as a radial probe.
Correct. Okay, so she's getting close right now. You can see that she's just angling the scope and trying to find which distal airway to send that into. So you want me
Yeah.
to you want to unfreeze?
Can you? Yeah.
So now what we could do here, right, is to see if we're in front of it.
Probably not the best one. I can change the bronchos.
Why don't you put it out, Michela, just so we could show them something real quick? Okay, so that's
Yeah.
out right now.
Yes.
And obviously, we don't have a radial image, but if we spin this to the right a little bit, go to, yeah, okay, good, stop. And then you could see that once it goes back on,
Yep.
we're
It's
close.
close to, but not
Close, but not perfect.
inside.
So it must be an airway that takes us off to the side.
Then the other thing to remember is the yellow ball was marked under.
Probably there is a better
So if we're not
airway
in
right
breath
here.
hold, it's not going to be exactly where it's located.
Looks like it's more in the middle. Maybe I can choose another one.
So what I would do is, okay. Yeah, so I think what we should do is come back a little bit more proximal.
Yeah.
And then pick another airway to go down.
Yeah, and then
The
Joe,
airway
make sure-
that you're in.
Joe, I would check under breath hold as well, just because that's where it was marked.
Can you give us a breath hold at APL 20 for a minute or two? 2 minutes of breath hold, sure.
Right now?
Yeah, just so it's not moving, because there's a lot
Yeah.
of movement with breathing. Okay, so. Good.
Okay. I think it's much better now.
It's matched there, but if we, now let's take it to LAO 20. So come to the other side, LA 20, and we'll see what happens. If we're in front of it.
According to the radial probe, we are in the middle now.
Okay, good, you could stop, Mom. But now you can see, so
See?
you spun to the
Posterior
left,
to it.
you move to the right, to your posterior.
Yeah.
So we're not in the right airway, so we just have to find the proper airway that takes you directly to it.
So that's an actual great example of how in AP you think you're spot on, and if you took your biopsy, you've missed, because she's obviously posterior to it, right?
Yeah, so this is my talk tomorrow, I don't have to give the talk anymore.
Yeah. He's giving you a call.
Joe, we'll record this for you.
Okay, perfect.
Sweet, we can skip Joe's talk tomorrow.
Yeah, it gives Sonali more time to talk. I'm like, this, I'm going to block. So you can see there's a couple airways in front of her here.
Yeah.
So it might be that,
Maybe we
one
choose
there?
not this one.
no,
Maybe this one.
maybe?
No. The other side. Still far. There is another one. Looks like I should go there with a needle because the radial probe is just pointing the
Let's
bronchus
spin
there.
it to, let's spin it to RAO and see what happens. See if we stay in the same spot. We might not be. We might be too anterior.
I don't know.
Just about RAO 20. You don't have to go much further than that. 20? Good.
Yeah,
Yeah, see, so now.
I like this
Move to the
position,
right,
but
you move to the left, and you're still a little behind it.
yeah, there is no bronchus in there. I need a needle right there where the radial probe is.
Unless
Right.
there's another airway parallel.
We can restart ventilation. Yeah, I would definitely go with a needle right there, Joe,
Okay.
because that's the right position and it's behind the bronchus. You put to 0, yeah.
So what we could do, Michela, and what we'll do, Kyle, is we'll put a needle out, and
Yeah,
then we'll do a spin with the needle.
absolutely,
Okay.
yeah.
So in order to do that, we need a breath hold. So once you start putting the needle in, I'll ask him to do another breath hold.
We can stop the
And then
radial probe
do a CABT. Yeah. she can
and
do
take it out. E metto il
No.
lago.
Okay, you ready?
And I go with the needle exactly where the radial probe was.
Once she puts the needle in, we'll go out to 40 degrees RAO and then we'll do a spin like before.
You can go?
Yeah. So, you see it, right? Yeah. Let me just wait for this to go in. Oh, sorry. What's this?
Okay, needle is almost there.
Tell me when you're ready, Michela. Okay, well,
Not yet.
tell me when you get out. Okay.
Almost. Can we pass the needle even if the scope is bended? I need the vision there.
You want me to move in? You want a more I moved in. Can you see it better?
Oh,
Can you see it on floor?
where is the needle? Right. Okay.
Okay. You see it on floor?
Yeah.
Good. Let's do a spin. Ready? Hold on.
Wait
Okay,
a second.
Maura.
Just a
Maura,
second.
you could get into
Okay.
position.
1, 2, you go.
Okay. Go. Oh, no. Wait, hold on. Let's start again. Hold on. Okay.
You
1,
can go.
2, 3. Go.
Hello? Hi.
I'm
On. Go.
doing that.
You can sort of see the lesion on the spin a little bit.
Yeah.
If you use your.
Okay.
Okay, sono a 0, grazie.
Okay. Let's see where we are. You want to do a biopsy while we're doing this.
I'm doing an aspiration.
Fuori mezzo.
What?
Aspiro, resta.
Just a second. Okay, perfect.
You can still see the screen, right, Kyle?
Yes.
The playing screen? Okay.
Yes.
So, okay, there we are again. Now in this screen, we'll try to find the lesion. There's the lesion.
Oh, wait, no, we can't see the laptop. No, sorry. We see the
They
fluoro.
can't see the doc.
We
They
see the
can't see
fluoro. We
the,
don't see the tablet.
they have to see the tablet now.
Okay.
I think you're off just a little bit. I'll show you.
I take the needle out.
Now we can see it.
Yeah, so you're a little anterior to it, Michela, see? There's the lesion.
So you can see the lesion again, and you can see that our instrumentation is beside it. Joe, can you highlight that again? Just to,
I will. So there's the lesion. Look, Michaela. There's the lesion.
Yes,
There's the needle. The needle's
Okay.
in front of it.
it was nearby but not inside.
And then we could look on the coronal. I'll show you on the coronal. There's the lesion on the coronal,
Okay,
and then
and the needle is
the needle's back.
close by.
Okay. So let me update your lesion.
and then will you show the 3D?
Yeah. I'm getting it.
I'm going back to,
There's the 3D image, and you could see here, it's easier to see this way. You could see that you're behind it. See how you're
Yes.
behind it?
that's very clear there.
Okay.
Okay,
Okay.
let me try again. Do you want to try again with the radial probe?
I think we should just try with the needle. The bleeding will make the radial probe, I think, able to be interpreted.
Needle is going out of the scope. It looks like,
So the needle's in the middle of it in AP.
yes,
So if Maro spins this 20 degrees, the 15 degrees to the right, let's see what happens. So you spun it to the right and it moved a little bit to the left. So you're still a little behind it.
Joe, can you
That might
remind
be
us, was
okay.
there a bronchus sign?
might be inside actually.
There wasn't. It was between, it sat between two bronchi. So if you come all the way to, if you do it, if you come to the left, Maro. Good.
Good.
So you move to the left, move to the right. You're still a little behind it. There you go. That might be a little bit better.
Yeah, needle out.
So are you on stage with the mirror?
So right now we can only see the tablet. I don't know if you wanted to show us the
No.
bronch screen and
Oh, we need to see the Bronx screen again. Can we see the Bronx screen again?
Okay,
the
Yeah, we're doing it.
and
We're
the
doing it.
fluoro screen, if possible, the fluoro screen.
And the fluoro screen. Yeah, the fluoro screen would be nice. So what happened there is we did another spin. We just moved, she navigated the needle into the lesion on AP, but when she spun to the left, it moved to the right. She was still a little bit behind it.
so I
But we
can try.
compensated with the scope to try to get a little bit more.
I actually chose the bronchus there in the
Are
middle.
you on the stage with Amir? Kyle,
What did you ask, Joe?
are you on the stage with Amir?
Amir and I are both sitting in the audience.
Oh, you're in the audience, okay. So Amir uses the scope a lot, and I was gonna say that the thing about using a scope to navigate is that you could move it a lot more easily than the extended working.
Then an extended working time, yeah. So I can choose between these three bronchi.
You can.
We tried all of them.
Ready?
We did a biopsy here.
So if you want, go to that one and see what happens. Go to
The other one is,
See where it takes you. Just go in and turn your fluoro on and see what happens. Like, you're gonna go on that one?
I need the needle there. Mauro, can you please move it?
You can send the probe that way.
Yes, I'm sending the probe there.
You want the, can
The radial probe,
you
please.
give her the radio probe, please? Oh, sorry.
Yeah, we are very proximal, but we want to choose the right one. Radial probe, please.
So what she's gonna do right now is she's
I'm
going
testing
to,
all of the
she's
three.
gonna go into another airway, see if she could get a better position. She came back more proximal. And see,
Do we have any information about the rows?
over freezer. Okay. What she's gonna do is she's just gonna send out the radial probe into the other airway. There you go. You can see it. You can see it going in. Now
Let
she's
me
gonna
see what
turn
it-
on the fluoro and see
Can
what
you
it does. You have the fluoro on?
No,
No, the wrong-
wrong one.
Yep. Very much.
So
wrong.
this,
Yeah.
airway is definitely not the right
No, we
one.
went to the other one.
So we went to the right one
And it's one of
here,
these two, so
but
send
we
it,
still have another one there on the left.
yeah, send it into the one on the left. That might be the good one you want.
Let's see where it goes. Yeah, it's. No. The one we chose,
Is there one further on?
I think the one we chose was probably the good one.
No, that one.
Mm,
No,
caduto.
There's presumably another sub airway in there that you guys are just missing, right?
Yeah, she'll find it.
No, no, that was definitely the best one. The one we chose before. You want the small one there?
It's optimistic.
It is, but she doesn't have a radio image.
No, it stops there.
No, I know.
No.
Nope.
No. Yeah, I think the only one is the one we took before.
Uh-huh.
It's definitely that one. And the one up.
Did you check those over there?
No.
Nope.
No. I think the one we chose is
That's
the
the
only
right one.
one.
Yeah, I don't know. So I think the other key thing is I think everyone's seeing, no matter, the whole idea of the tool is being able to know where the lesion is. And honestly, in this case, know that you're not in it yet, right?
No. The only one
We
is
have to make further adjustments.
right here.
What's that?
So there's two airways in there.
Yeah.
Yeah, keep pushing. Looks good.
That's some promise.
Oh, look, see?
Yeah.
It had something.
The same as before.
Was that the same as before?
Yes.
Do you want to look at LAO just to,
Goes a little bit farther.
But maybe she could,
might be the blood, yeah.
it might be the blood. There's two airways in here though. And she might be in one and not the other. You bring your scope down in here. Dave. Not that one.
Not that one.
No, I don't think so.
Not the other one.
No, there's two in the one you were just in before. The only one you were just in before. So in that one, right? You were in that one before? You were in that one here? There's two back there. See, there's two. There's
The
on the
one
top, one on the
lower.
bottom.
I'm going to the one on the bottom.
Maybe it's the one on the top that you need.
Okay, let me go to the one on the top.
Yeah.
This is the one on the top.
Yeah.
Goes very fast.
Yep. I think the one on the bottom is your best bet.
Now, I think there's a practical side to this too, because of the yellow ball being what you confirmed with a tomo image. Now, obviously, maybe we're having hemorrhage.
Oh, it's definitely.
But
If you look at
Yellow
the
ball
radio,
doesn't change, so your rebus view may become garbage just of the practical
I
side
would
of
go
life.
with a needle right
But
there.
the tomo doesn't change. Now, if you did a redo spin, you may not get a good image because of the blood interfering, but you can still believe the yellow ball, even if your rebus probe is doing what it does.
What do you think? It's definitely the right one.
Yeah, it's the right one.
Yeah, right here. We want to make sure that the probe is inside. But we know that the probe is inside. I need to go there with the needle.
I would go with the needle and do another spin and see where we are.
So we don't move the scope. We
Don't move the
stop
scope.
the radial probe, take it out, needle.
Needle.
The good thing with the needle is that it can go actually
We're gonna go
everywhere.
again with the needle,
Yep.
and Michaela's just gonna angle the needle into the yellow ball. She's gonna try to get it in, right now she's sitting, the fluoro is an REO. So put the needle out into the ball, we'll spin it to LAO, we'll see if we're in a good position. Right, you want to be in the same position, with at least a spin of about 15 to 20 degrees.
Yeah,
difference.
so you're good. Keep an oblique slash.
Maybe we
lateral view
can
like
ask
that.
for a breath hold.
Yeah, we have it in the oblique right now, REO.
The needle right now should be inside the lesion.
Okay, so let's spin, Amaro, can you spin to the left a little bit?
There we go.
Spin to the left a little bit. Good, good. Let's see where we are. Let's see if it stays in the
Yeah.
ball. Did it stay?
A little bit off. There it is.
It's a little bit off, but not much. Maybe she could angle that a little bit. See, Michaela, you just have to, yep. And then see if you can push it out into that. Yeah, just like that.
Yeah, it's even too much.
Okay. You want to do another spin here, another Tomo spin? Can you give me
Okay.
a breath hold, please? Okay, we're gonna do another spin here.
One.
Oh, we don't, Stefano, can I over five, can you go to AP first? Go to AP, sorry, it's making me go to AP. Go to AP first. And then, once you get to AP, give me a press on the foot.
That's it.
Okay. Did the table drop by anyone? Any means? They want the table to drop a little bit. Drop the table a little bit, or raise the artist a little bit, just a little bit. Okay, that's good.
Okay.
That's good. Okay, we're gonna do it again, tap.
Okay.
Good, okay. And you're in breath hold, right?
Yes.
Just a second. Need to go.
Breath
Tell me-
hold.
You ready? Tell me when you're ready to go, Baudo.
Ready to go.
You want to count down?
1, 2, 3. Go.
Okay. So we're just gonna do another spin here, Kyle, and audience.
Okay, great.
So as you saw, Michaela manipulated the scope and the needle a little bit. Good. Done? Benito?
Done.
Okay. Now let's do a reconstruction while she does the biopsy.
We can ventilate the patient again.
Yes, you can ventilate the patient again. You did already.
Needle out. So we are getting another
See the screen
sample.
there, Kyle, on the control screen?
Okay. Stop.
I mean, it looks pretty good, Michaela. I mean, it looks like, there's some bleeding there, but it looks like you're kind of where
Yeah.
you should be.
Can you show us
It's a little bit more angled compared to before.
can you show us the tablet, Joe, if you're
Can
playing
you
with
show
the
us the
tablet?
tablet? I'm on the tablet. Can you give us a view of the tablet?
There it is.
I mean, we're right there.
Yep. You're lined up.
Right.
Yep.
We're very lined up. You can see the needle. You might not be able to see it, but we can see it faintly
Yes.
to that nodule. So it's right there. So maybe you have here's aitomo. There's the needle right there.
Yeah.
See the needle? Oops, that was my fault.
More posterior now.
But not too bad.
Can I have a forceps as well?
I mean, look, there's a needle right in it. See it?
Right in, yeah.
Yeah. So let's go to the 3D. Let's go to the 3D view.
The patient is breathing? Yes.
Yeah, breathing.
Fine.
We look like we're pretty good. We're just a tad bit to the medial to it, but we look pretty good here. So anyway, it looks like we're in a good position here. She's going to keep doing biopsies. Eventually, the blood is going to get in the way. But I think we're going to just keep doing biopsies here. I don't know if you want to take it away here, Kyle, and we'll let you know when we come back if
Yeah.
we get the diagnosis or not.
Can you open the
But I think
forceps?
I have a very encouraging view, of the
Close it.
of the TT. Unless you have anything to add.
Yeah.
we'll let you guys carry
The
on with
body
the
vision
biopsy.
picture can tell you
And,
where you
uh,
have.
Keep going, they're
spot
gonna,
for the
they're gonna
lecture.
show.
Absolutely.
Yeah, why don't you do that, Paula? We'll let you know. Thank you.
Thank you.